Welcome to Palliative Care in Rural Settings, the medical education podcast aimed at providing bite-sized education and information for doctors working in rural and remote Australia. Today we'll be having a discussion with Dr. Alison White, a palliative care consultant in Royal Perth Hospital's Palliative Care Consultancy Service and the visiting physician in the Kimberley Palliative Care Service. Dr. White will be discussing with Grace delivering palliative care in Western Australia, decision-making around ongoing treatment, having discussions about palliative care quality over cure, and using of medications and their availability in the rural setting, with an emphasis on end-of-life prescribing.
Alison, can you tell us a bit about your experiences as a palliative care physician probably mostly in the Kimberley palliative care team?
Thanks, Grace. Yes. So I'm the visiting palliative care specialist with the Kimberley Palliative Care Service. So I'm based in Perth, but travel up to the region around 4 times a year to spend a week at a time with the team in different parts of the region. And in that role, I obviously provide predominantly medical advice. The Kimberley Palliative Care team is made up of a nurse coordinator, as well as a palliative care clinical nurse, a social worker, and the state's only Aboriginal health worker working with the palliative care team. That team is based in Broome, however they service the region throughout the Kimberley, so obviously covering very vast areas. Their role is really in providing support to treating clinicians across the region. So the team is not designed as a case management team or to take over care from the local treating teams, but rather to provide specialist level support around symptom management, support and assistance with concepts such as advanced care planning, facilitation of family meetings and discussions with patients, as well as some support around equipment, in particular things like syringe drivers and accessing medications.
So if I've got that correct, you actually are saying that local clinicians, doctors, nurses, etc., work collaboratively with those teams?
Yes, very much so. And the local clinicians, GPs, hospital-based doctors, nursing staff and other caregivers form the primary management team for the patients and continue to direct the care. With regard to symptom management and some of those more specialist palliative care needs, the palliative care team will then provide some support and advice.
So I presume that means is that the same across the whole of Western Australia?
That's a good question, Grace, and I'm not sure that I can answer specifically because my experience is limited to the Kimberley region. I'm aware that other regions do operate in a very similar way, particularly in the Pilbara, the wheat belt and the goldfields will have a similar model of care. In the Great Southern region, there are resident palliative care. There is a resident palliative care specialist as well as palliative care trained GPs in the area who will oversee the care in that area, and there are inpatient services there. Similarly in the southwestern region where there are resident palliative care specialists, so there will be a slightly different model of care in those regions.
If we just think about the Kimberley region, do you find that there's quite a diverse range of clients and areas where they're living and what services are available for them?
Yes, absolutely. And certainly from my experience, which is predominantly in the metropolitan area, there are some really vast differences. I guess something that has struck me is that there is a different proportion of malignant to non-malignant diseases, where in the metropolitan region, most of the referrals to palliative care are for cancer-related conditions. In the Kimberley Palliative Care Service, we will have a higher proportion of patients with chronic diseases, as you might anticipate, in particular end-stage renal failure, chronic obstructive pulmonary disease, congestive cardiac failure as a consequence of rheumatic heart disease and things like that. I think also the burden of comorbidities is very high. And unfortunately, the age of many of our patients is younger than we might see on average in the metropolitan area. Additionally, the area serviced by the Kimberley Palliative Care team is obviously very vast, and patients may be geographically isolated and therefore have very limited access to medical supports. This is particularly true in the Kimberley region, which is affected by the climate. So throughout half of the year during the wet season, patients and their families may actually be physically cut off from services, and that has really played a part in some considerations as to how patients may be managed, how we need to get medications and supplies to them, which is obviously vastly different from the metropolitan area and other regions. So I think that there are some really unique challenges and differences from the palliative care that I would practice here in Perth.
They're really marked differences, and I think that if we can now look at the way that you work in the metropolitan area, and mostly in some of the inpatient facilities in some of your clinics, can you outline some of the differences in providing palliative care in regional WA that you would think most clinicians would be able to identify to being able to do your treatment or care in palliative care here in the metropolitan area?
One of the obvious differences in the care for patients in the Kimberley region is the distance to access some of the treatments available for their various conditions. So, for example, for patients with malignant or cancer-related diagnoses, they are geographically really isolated from treatments such as chemotherapy or radiotherapy. So for them, that may impact upon the decision to receive even palliative intent treatment in those instances. So that's certainly one key difference, and that may lead to different treatment-related decisions which may have an impact on how we might be able to manage symptoms or even what the life expectancy may be for some patients. Other differences is that there is no specific inpatient palliative care service across the Kimberley region, with no resident palliative care specialist, palliative care specialist nurses providing hands-on care for patients. So we are really keen to support and educate and capacity build within the resident medical services with the GPs, the hospital-based doctors, the nurses and the caregivers across the region. There is no 24-hour palliative care service as there is within the metropolitan area. So we're very fortunate here to have the excellent Silver Chain Hospice service, which can provide 24-hour access to community palliative care, while in the Kimberley region, unfortunately, there is no such care. So we're really very much dependent on the local services and their ability to provide that care, but also on patients, carers and family members as well to assist. So the palliative care team, therefore, is really involved in education and support for family members as well as the local practitioners.
And I believe that, as you alluded to before, there's actually different processes in different palliative care, rural WACS palliative care teams. So some will actually run on a model of offering in-home care. Some will actually offer some more support to the acute care setting, and people have very little options but to come into a actual acute care setting for end of life, for example. So it is something that we would really urge people to really start to connect with their palliative care teams. And would you have a view on that about when people should and how clinicians can better work with their palliative care teams?
Yes, I think that's a really good point, Grace. I think that the earlier the involvement is with the palliative care team, the better. There are many tools that can help to assist in identifying when a patient may have palliative care needs or be appropriate to refer to palliative care. So some of those tools will include the SPICT tool, for example, which delineates some of the factors that may prompt a recognition of palliative care need for a number of different conditions, including dementia, heart failure, cancer, and other chronic illnesses. Another one is called the Gold Standard Framework, a similar concept, but even just asking the question, would I be surprised if this patient were to deteriorate and die within the next 12 months because of their life-limiting illness, I think provides a really good way of being able to recognise that a patient would benefit from palliative care team involvement. The reason I say that the earlier the involvement, the better, is that one of the primary things that we are aiming to achieve in palliative care is to understand the goals and the priorities for the patient and their family. And in order to do that, we really need time to be able to get to know the patient and their family, to develop a rapport, because some of the conversations that are required are very sensitive and they're difficult, and you can't just have them in a big hurry. In thinking about the Kimberley Palliative Care Service, and coming back to the point that we talked about earlier in terms of the geographical distances and the fact that patients may be physically isolated, we actually need time to ensure that we can firstly have these conversations. So we need to arrange video conferencing or tee up a time when one or all of the team members may actually be able to travel to that region in order to have some of those discussions. We also need to then ensure that the area is able to access the necessary medications, equipment and other things that the patient may need. And sometimes, there can be a delay because medications may need to come from one of the regional centres or even from Perth in some occasions. So I think that involvement early is important. When involving the palliative care team, there is not a sense that the palliative care team is then going to take over care or demand that various care is withdrawn. Rather, that the team will work with the local care providers and be able to adjust the care as is required, as determined by the patient's care needs and their symptoms. Palliative care also doesn't need to be involved continuously. So once a referral is made, there may be an immediate palliative care need, for example, a symptom such as pain, which can be addressed. Some discussions around advanced care planning may be begun. But then the patient's condition may stabilise, and it might be appropriate then that the palliative care team step back and allow the treating local practitioners to continue their care, but at a point in the future, then the palliative care team might be able to step in again when it's recognised that the patient's function is declining and their goals of care may have changed.
That's a really interesting point about making sure that we don't believe that palliative care is there to take over. And one question that's been brought up through other areas of discussion have been that a lot of places in rural and regional areas are supported by locum doctors, and I presume being with a palliative care service would mean even though perhaps there's a change of clinicians with a changeover, would you be urging those specialists or those clinicians to actually use the palliative care team to be able to make sure there was continuity of care? Because I think there's sometimes a concern that I'm only here for X weeks, and there can even be a reticence to do order tests or those sort of things because, I'm not going to be here to have the response, and how do I hand that over?
Yes, I think that's another really good point. Certainly the health professional network within the region is quite itinerant. I think as a doctor it can be very difficult to be able to recognise a patient's changing function because you might only see them once or twice, and it's very difficult to have some discussions, particularly around things like advanced care planning and goals of care setting discussions when you've only met the patient once or twice. So yes, I think that the palliative care team can provide, at least in part, a process of continuity of care, certainly. I think it has worked well where I've seen the palliative care team link in with one of the locum doctors to be able to facilitate some of the advanced care planning discussions, as well as get some formal documentation, for example, on an advanced health directive, using some of the local-based health information services such as Communicare to have that documented so that doctors coming in can then see what those discussions have been and what treatment limitations, for example, have been put in place, or what processes have been started for symptom management as well.
We talk a lot about the disadvantage or the more difficult components of being in a client in a rural area, perhaps with the viewpoint that they may not be getting the same treatment as in the metropolitan area. But could you actually highlight some advantages for people being where their home is?
Grace, I think there are lots of advantages to providing care in a patient's hometown. We know from population studies that the majority of patients wish to receive their end-of-life care at home. So really we want to work towards supporting that as much as we can. Within the Kimberley region, we have many Indigenous patients, and for Indigenous patients the connection to their country is so vitally important, so it really forms a critically important part of palliative care, that spiritual care for patients to be at home with their family on their country, and I think that we can't overstate the importance of that. I think also that for many patients who have been living in that community for a long time, they're going to have so much support within the community networks, family members, caregivers, other people around who can provide some of the care that they're needing. So that's very important. The climate change of coming to Perth is very difficult for lots of patients within the Kimberley region, so there are many advantages to providing that care within the region. And look, I think that the health care professionals in the regions are actually really dedicated, often know the patients really well because they might be frequent flyers to the clinic or to the hospital. So they're really dedicated to providing excellent care for these patients, and I think that it can work actually really well. From a very personal experience, I was involved in the care of a family member in a regional town in New South Wales, and we linked in there with the Rural Palliative Care Service, and I can't speak more highly of the community spirit that I witnessed as part of that care, and the support that we as a family received from the healthcare professionals, from the palliative care team, but also from the community, would not have been possible had we cared for our family member in the metropolitan area, which wasn't his home, where he didn't have those networks. So I think that is really an extremely important part of that holistic care of the patient.
I think the important thing that you've outlined there, along with many others, is the whole idea that we should be working as a team with the client in the centre. So perhaps looking at the way we practice in regards to seeing what the person needs rather than sometimes that what bit of medical treatment is required sometimes. Do you think that's a reasonable statement?
Most definitely. I think that one of the most important things that we practice in palliative care as much as possible is to engage the patient in decisions about treatment, including where they want that treatment to be, who is involved in decisions about their treatment. So all of these things are really very important, and asking the patient those questions when you can is very important. I have had patients from the region who in fact don't want to be at home. I don't even mind if they're in their hometown for the end of their life. So you can't presume in any situation.
So palliative care, as you've highlighted, is very much about having discussions with patients, families, but also team members. Can you share with us some thoughts from your experience, perhaps, on having discussions around palliative care and perhaps how we help to change the emphasis from treatment to quality and self-determination?
I think here it's really important to frame the discussion in a way that enables the patient and the treating team to have a common understanding about what the patient's priorities are, and what determines quality of life for the patient. Many discussions around treatment limitations or, for example, resuscitation discussions in the past have been phrased to the patient in a way such as, in the event that your heart stops, would you like us to do everything, or would you like us just to keep you comfortable? And it's not really phrased in a way that a patient who often will have a limited health literacy can possibly answer that question from an informed viewpoint. There is increasing evidence, and I have found in my experience, that it can be helpful to try to understand for the patient what provides them with quality of life. For example, in asking the patient whether they would feel that an acceptable quality of life would still be possible if they were in a position in which they couldn't complete their own activities of daily living, if they couldn't attend to their own personal hygiene, if they were dependent on others for toileting and for eating, for example. If that is not an acceptable quality of life for the patient, then it helps to inform the medical decision as to whether further treatments would be of benefit. So I think that is the way that I would hope to frame some of those discussions. Whether or not an interpreter is needed for patients, obviously there are very diverse language groups within the region.
Often it's very difficult for clinicians to actually engage with family, and that concern of who am I meant to be speaking with and what the advantages are in including family in those discussions.
Yes, that's another really good point, Grace. So certainly I think making sure that we identify who the right person to speak with is very important, and identifying who the surrogate decision maker is important because we know that as patients deteriorate, the vast majority will lose the ability of being able to participate in conversations about their care. So we really need to be able to know who to speak with, should we need to inform them about what's happening for the patient, but also in terms of being able to make some decisions about care. Now, particularly in the Indigenous populations, who the right surrogate decision maker is vastly different from who it may be in our usual Anglo-Saxon family hierarchy. So that's really important, because in speaking to the wrong person, we're really not doing the right thing culturally.
Alison, we've discussed what palliative care can look like in regional and remote areas and how we can be more supportive of our clients. But then a large percentage of people we would be seeing sometimes don't come to us till close to the end of life. I'd really like to discuss end of life around what medications may be standard or things that you would predict to use at end of life, and perhaps we could really look at how we can better help clinicians that this isn't their usual area of line of work.
Yes, sure. So I think towards the end of life, when patients are approaching the terminal phase, it's really important that we are able to support staff to provide symptom management around a few key symptom areas which we know are common in the terminal phase. So we want to preemptively prescribe for symptoms including pain, shortness of breath, nausea, agitation and distress, as well as terminal secretions. Not all patients will need medications at the end of life, or they may need medications only intermittently, as their symptom burden may not be significant. For other patients, they may require continuous administration of medications because their symptom burden is quite high. So we need to have a flexible approach. But generally, I think making sure that we have medications to cover those main symptom groups is really important. So in thinking about pain and shortness of breath, we would usually use an opioid. Often morphine would be quite adequate in this situation. And because we know that patients' ability to take medications orally is going to decline, we would often use medication via the subcutaneous route, which can be administered using an intima, for example, that can be placed and then left in situ so that the patient doesn't have to have repeated stabs. So morphine may be quite appropriate to manage pain, also to manage shortness of breath. Sometimes we may suggest an alternative to morphine. For example, we might use something like hydromorphone for a patient who has renal impairment. The dosing of the opioid may change depending on whether the patient has required opioids previously for the management of pain or shortness of breath. They may require a higher dose as they're approaching end of life. That would be something that we would titrate according to the patient. For nausea, we may use something like subcutaneous metoclopramide, or we perhaps could use subcutaneous haloperidol, which has the advantage also of providing some control for agitation or restlessness, as we know, unfortunately, that delirium is very common towards the end of life. Midazolam or subcutaneous midazolam we will often use also to manage restlessness towards the end of life. And we will usually use an anticholinergic medication, for example, subcutaneous glycopyrrolate or buscopan or even atropine to manage terminal secretion.
The availability of these common medications that you prescribe at end of life, is there a limitation for some areas? And can you describe, perhaps through a case or an example, how you've actually been able to deliver this in remote places?
So most of the remote areas have access to these medications, in my experience, or some form of medication that we can use. However, going back to our earlier point about the earlier involvement of palliative care is really helpful to ensure that we have been able to preemptively prescribe these medications and make sure they're available. So I can think of a number of examples of patients who have been in remote communities in the Kimberley region who have required, in fact, a continuous infusion of pain relief and midazolam, and really the only way for us to be able to deliver that is via a syringe driver. There are a number of syringe drivers available in the region, but of course they're not necessarily based in a remote community, so the palliative care team is able to get that syringe driver out to the community and provide education for the nurses in that remote area as to how to use the syringe driver. We have had experiences where it would just not be practical to use a syringe driver. So we spoke before that there's no 24-hour palliative care service across the Kimberley region. So that makes it quite tricky for a patient to be cared for at home in some circumstances where we might use a syringe driver, for example, in the metropolitan area, where we would use the community palliative care service to change that syringe driver every 24 hours. So we can use different strategies to manage in that circumstance. It might be quite appropriate to use, for example, a transdermal opioid administration, so we might use a Norspan patch or a fentanyl patch, for example, to provide a continuous background opioid. We might be able to use a longer acting benzodiazepine, for example clonazepam, which we can administer sublingually to provide some relief of restlessness. We can use sublingual atropine drops, for example, to manage terminal secretions. We might be able to use a sublingual antiemetic to manage for the potential of nausea. So there are other strategies that we can use. However, there may be a limitation to the accessibility of those medications because they're not impress stock. So if we can anticipate that and make sure that we can order that, and in my experience, we've been able to get medications within a relatively short period of time, but that might be 24 hours, so we do need a little bit of planning ahead to make sure that we can do our very best to provide the best symptom management and support for the patient in the location that they want to be, along with education for the nursing caregivers or for family members or carers who are going to be looking after the patient.
Alison, there are often concerns for clinicians who perhaps this isn't their area that they often work in or that they're exposed to, about preemptive prescribing and the concerns that what if they get it wrong, or perhaps not with a lot of confidence in the people that would be asking to deliver this medication. Could you describe for us what the absolute advantages of preemptive prescribing are over responsive prescribing?
I think the palliative care team has a really important role here in providing support and education to carers, be that nursing staff on the hospital ward or family members in a patient's home, as to how to use preemptive medications so that we can ensure that preemptively prescribed medications for symptom management are being used appropriately. Within the Kimberley region, the care plan for the dying patient was rolled out now, I think it was probably around 18 months ago. And that has provided a really clear guidance as to how we should be assessing patients in those final hours and days of life, and how nursing staff may be able to respond to patient symptoms. So that provides some, I think, some really clear, structured guidance to assist carers in providing really good and appropriate care for those last hours and days of life for patients. So I can think of an example where we were concerned about the opioids in a patient's home with family members perhaps having some difficulties there. And in that circumstance, perhaps we might want to review whether it would be appropriate for the patient to remain in the home environment, for example, or maybe we might liaise with the local pharmacy about reducing the quantity of the medication in the patient's home. We may need to work more closely with the carer in that circumstance to ensure we're doing the very best thing for both the patient and for the carer in that situation. In my experience, that doesn't happen often, but if it does, I think that's a really good example of a situation where getting the palliative care team involved, getting that support is really helpful.
Alison, you've really outlined the importance for clinicians to contact and work with palliative care teams in their areas early, and it may be over a longer period of time and then through end of life. But how can some of the clinicians listening today get some extra support from a palliative care specialist?
So there are a couple of ways. I guess firstly, through involvement with the regional palliative care team, we'll put you in touch with the visiting specialist or the resident specialist in the area. And I imagine that each area will have a way in which that specialist may be available to you to provide some advice. There is also a really invaluable palliative care outreach service, which is available 24 hours a day, 7 days a week, where clinicians can ring through and speak to a palliative care specialist and seek advice and support with regard to symptom management, prescribing, and other matters related to palliative care. So that number is 1300 558 655. And you will get straight through to a palliative care specialist. The palliative care specialists on the outreach number there do keep a record of phone calls that are made. So if you then ring through at a later stage and get another a specialist, there will be a record of what's been going on to provide some continuity of care. And where possible, we do try to hand over to each other. So certainly I have had some of the doctors on the outreach service let me know about patients in the Kimberley region who might need some ongoing assistance. There are also a number of different resources available through the WA Cancer and Palliative Care Network, as well as through the Cancer Council and through the PACE program as well. Support is definitely there, and you're most definitely not alone in practicing in this space. The 1300 number is there 24/7. The palliative care teams in the regions are there, and we certainly want to be involved and want to provide support where we can.